now, I know we're coming to the end, and we again so appreciate your time. It's so precious. Share with us a little bit, because you are an addiction specialist. You run a program for medication-assisted treatment. So we have this, you get this client who you know is struggling or has struggled with opiate dependence and addiction, and now wants to get help and wants to go into recovery. So how do you treat them? Like, what steps are done?
By the time they come to my practice, I feel like there have been ways to attempt to reduce the pain medications that the prescribers are giving, that the family has possibly intervened. And despite different interventions, that person is still using and still cannot stop using that substance. And there's a number of different ways that people can get help. There's detox units that are inpatient-based, residential-based units that could be very short-term, that would really just give people a sense of comfort medication, some emotional reassurance, some groups. And for some people, that can be very helpful. That short-term detox under the supervision and observation of healthcare providers 24 hours a day can really help people to do that detoxification instead of doing it at home and dealing with their withdrawal symptoms. Many people need a longer term of residential treatment, such as a rehabilitation center, where after they go through those physical withdrawal symptoms and they're feeling better and they may be eating better and sleeping better, they can actually focus on a lot of those lifestyle changes that need to be made, avoiding people, places, and things that might be facilitating that addiction, maybe focusing on some of the healthcare, their medical needs that may have not been attended to in the midst of addiction, maybe getting them back on their feet financially, reestablishing relationships. So that takes time. But that's not always available to people. And I think based on that biology that we spoke about, I think for that very reason, we can't always say that that is the answer for everyone. It's not a one-size-fits-all situation. And what I do is I treat a great deal with buprenorphine maintenance treatment. And what buprenorphine is it's an opiate agonist and antagonist. So it's slightly different, even though it's in the quote unquote opiate category, it's slightly different in the way that it has that antagonist effect. So for instance, it can be misused. It can be misused in the opioid naive person. So if there's a school child in high school or somebody experimenting and they've never had these medications, it can cause some euphoria for them. So there is some illegal activity that could potentially happen with that, although not so much. If anything, people are selling it on the street in a way to trade it for the opiate of their choice. Not necessarily, it's not really out there because people want to abuse it so much. So there's less abuse potential for it. And when the person is not naive to opiates, the person that's coming to me for care, what happens is it sits on those very receptors that have grown in that person's brain. So we talked about the fact that the brain builds more and more receptors as people use over time, and that brain wants to get more and more of that opiate into their body. Well, because we have all these screaming receptors, sometimes the detox unit for 3 days or so does not work for them, because you could be as motivated as you want to be. You could be gung-ho on wanting to end this behavior, but you can't do it because of biology, because you have those screaming receptors that want it, and it's going to cause intense cravings for most of these people, and more likely than not, they're going to end up seeking out that substance again and using. So the buprenorphine, when taking this medication, will sit on those receptors, make the person feel satisfied because it is quelling all of those intense cravings. And the person, for the first time, which is almost miraculous sometimes, feels normal and acts normal and can sleep and can eat and can function. And in such a short amount of time, people will say, you look younger, you look so healthy. What are you doing? And they can go back to work and they can take care of their children and do all the things that they weren't able to do before. And it really is because of biology that it does work so much. The other thing I like about it is it's so safe because it has a ceiling effect. So maybe someone may have this idea that if you keep taking it, maybe you will be able to abuse it. And that is not the case. So what I mean by ceiling effect is, even if you took 10 doses of it, once those opiate receptors are saturated with the medication, it won't do anything else. So it won't create more of a euphoria. It'll simply do the same thing that a typical dose will actually achieve. And once somebody tries that, if they try it once, they're never going to try it again because they know it's not going to really be successful in achieving any euphoric state for them if they take higher doses. So in that respect, it's much safer than the opiates on the street. And you really would want to be on that maintenance dose. Once you find that appropriate dose where the cravings are to an absolute minimum or have stopped completely, and the person is not having any relapses, that would be the appropriate dose for them, which is typically 8 milligrams twice a day or so is about the average, 16 milligrams a day. That person should really be on that medication for possibly 9 to 12 months at minimum. And the reason I'm saying that is because people really need to be patient with themselves, allow those receptors, really takes that amount of time for those receptors to go back to the usual amount. And then over time, people may say, oh, I was busy, I missed that dose, and I didn't even have any cravings, nothing. You know, I still felt like myself. That's because naturally over time, people will need less. And I think people also need to remember that they don't want to underestimate the amount of small changes in the taper when the time comes to taper that medicine that they have to do. So they really don't want to do it on their own. And I'm always impressed by how, people want so badly when they feel normal, they want to go off the medicine. I have to really spend a lot of time convincing people after a couple months when they feel good that, no, your body is really not ready to go off that medicine. And when that addictive behavior goes away, they just want to be on the least amount of medication, just like everybody else. And, but I just try to explain to them, be patient with that. And when it comes time to tapering, we're going to do that together, because I think sometimes people get ahead of themselves and may feel like, oh, these little doses don't mean anything. But actually, you really would want to only taper maybe by 1 milligram to 2 milligrams per month at the very quickest. So your body needs that adjustment time in between so that your body doesn't even recognize that it's going through any changes and any taper of the medication. So in my opinion, I just feel like it's the most amazing medication for the majority of opiates in terms of opiate addicted patients, in terms of the success rates, are incredible, and being able to be productive in their lives and having satisfying lifestyle changes that they can achieve with it. There's also what they call Naltrexone, which is sometimes referred to as Vivitrol, is the brand medication. That's actually an injection. Now, that medicine is not an opiate agonist, meaning it's not opiate-like in the way it works in the body, but it's strictly a blocker. So it will block any opiates from coming into the system. And some people can take this either by oral pill, naltrexone, or it can be converted to a monthly injection for people that are afraid that they might be tempted to skip doses, or possibly it's just more convenient to just be able to get the injection every month. And that can be very successful. So I don't want to say buprenorphine is the only way to achieve it, because many people would like to have some medicine assistance without an opiate-like medication. And they can have a lot of great success with that as well.
I hear you. That's such an important thing. Now, is there a difference between who you would choose naltrexone as opposed to who you would choose buprenorphine?
In my opinion, the best time to start naloxone, a really good opportunity to start naloxone, is if somebody does a detoxification program in inpatient residential treatment, then goes into the phase of rehab and actually starts that medication then. And the reason I suggest that is because you really need to be 7 to 10 days opiate free before starting that medication. And it's the perfect time to get adjusted with it. And then within that time frame, after you leave the rehab and go on to your life, if you're tempted to use something, it will block it. It's not foolproof. If you take enough of a potent opiate, you can push through that blockade. And that could be potentially dangerous for people, because there could be overdoses by people trying to push through that blocking effect. But like I said, in many people, it can be very successful. The difference with using buprenorphine in an office-based setting is so much easier, because you really, for short-acting opiates, really only need 24 hours without that medicine, which is a lot more achievable to be opiate-free for 24 hours, or with a longer-acting opiate such as methadone or OxyContin, for instance. Some of the longer-acting opiates, you may need up to 72 hours. But even that is slightly more achievable than to go 7 to 10 days opiate free with all those screaming opiate receptors in our brain. So I just feel like it's a lot easier transition for people. Some of the detox units use short-acting buprenorphine to help people get comfortable these days and transition off very quickly, so they don't have a lot of painful, uncomfortable withdrawal symptoms. So it's a very humane way of a detox to make people comfortable a lot quicker. And there are some people that still do methadone maintenance, which is still a very viable, very successful treatment for people. It's not as convenient, because with methadone clinics, you have to present to a clinic each day to get your dosing. And because it's very long acting, maintenance dose sometimes has to be high enough to reduce those cravings. And it may take up to a year longer to actually taper that. Whereas with Suboxone and buprenorphine and those other brand products, Bunavail, you can actually potentially in 6 to 9 months or so taper off an average dose.
Yeah, so it's just easy to come off of the Suboxone, buprenorphine, as is it for the methadone?
Is still for pregnant women, methadone and buprenorphine are considered the drugs of choice. There is that added blocker in Suboxone that is not safe in pregnant women. So those people would want pure buprenorphine, which is sometimes the brand is called Subutex, or methadone. But a lot of studies will say long-term use of buprenorphine is very, very safe. Even if people are staying on it for years, most likely more so due to fear of a relapse, not that their body really needs it. It's more of a fear of not being successful. But those people really don't have long-term effects. Methadone can have some potential longer-term effects, like dental issues and weight gain, a lot of sedation with it, and a little bit more complicating factors. So I still feel like for a lot of reasons, just for convenience sake, safety, long-term use, that buprenorphine is possibly a better choice, but not for everyone. Some people, methadone is still the best choice for them.
So it all just depends on a case by case. And I guess that's why it's so important to stay in touch with your provider, never to change medicine on your own. And if folks do have side effects, then immediately report them to the provider as well, right? Yeah. Dr. Madrick, lastly, besides medications, is there anything else that these folks who are in recovery should be doing to help themselves?
So it's just not medicine, and it's not that medication can fix everything. And I think in most cases, whether it's a medical condition or otherwise, especially with addiction, that we need to look at other things. So you really need to make some lifestyle changes. For one, you have to have good nutrition, because I think that most people do not pay attention to their diet when they're in the midst of addiction. Many people have weight loss. Many people are not eating healthy food. So nutrition is very important. Getting adequate sleep is important. Really looking at people in our lives. Sadly, we may have to break some ties with people that may not be good for us. If there's still people that are actively using in our life, we may have to separate from those people. Certain places we may have to avoid, certain situations that may trigger us to relapse into another use, which is hard in itself. But also, I think it's really important to have individual counseling, and it's recommended with methadone maintenance and buprenorphine maintenance and any MAT treatment to do counseling as well. So it's not just the medicine aspect, it's about dealing with what are the stresses in my life that might be a trigger for me to relapse. What are things that have been difficulties that might facilitate use? Is there comorbid depression, anxiety? Are there histories of trauma in our lives that we are trying to escape from? And if we have these reliving experiences of intruding thoughts about trauma that are causing us to want an escape, then to deal with that, whether it means other types of treatment, such as medication treatment, like antidepressant treatment, as well as talk therapy. And really, the support groups are tremendous help for quite a bit of people. We have, the 12 steps, and that's what I was referring to with the anonymous support groups, whether that be Alcohol Anonymous, Narcotics Anonymous. There's also Al-Anon and Nar-Anon for family members. And there's a lot of support groups just for mental health issues in general that families can get involved in, and to the patients themselves. So really, it's a whole mind, body, spirit concept of really making complete changes in your life, because if one area is still the problem, then it's going to be another source of relapse. Maybe that stress is, a job that is too difficult to maintain, or a marriage that is too difficult to obtain. And sometimes people have to make, those appropriate changes in their lives in order to be successful in the recovery process.
Yes, absolutely. Such an important thing, because I can tell, in our field, I think we see very limited, or rather we hardly see clients who may just have like a pure opiate dependence or pure addiction. There's always things associated with it, underlying factors, which actually made them go on to this route by whether accident, by choice. But if we don't address those things, then I think we're just addressing the surface level, not going into deeper areas. Yeah. Dr. Madrick, what % of your clients that you get in under this opiate dependence and addiction, do you actually see other psychiatric conditions, or, as you said, trauma?
Probably close to 80%, definitely more than half. 70 to 80% of those really do have some other issues, whether it's trauma issues, anxiety issues of some type, panic attacks, depression, bipolar disorder, even other chronic mental illnesses such as schizophrenia. And also we have to remember those chronic pain issues and those medical conditions. And, if that's what started the problem, really addressing those things. Are there other ways? Are there different alternatives that could be used aside from narcotic agents, whether it's steroid injections or acupuncture or chiropractics, other manipulations, physical therapy, using all of those other strategies of dealing with those pain issues, surgery if it's indicated. Unfortunately, there's a lot of different surgeries that are much more minimally invasive that are a lot safer than they had been, fortunately, even 10, 15 years ago. So could these things be addressed in different ways so that people can have an overall better quality of life?
Absolutely, yes. Well, Dr. Mehta, you just said some very helpful tips for our folks out there, for those who don't quite understand opiates, opiate addiction, but now with all this information, we're just hoping that they're way more aware of it in the future. We like to give hope to our clients. If you can shed light a little bit about one, when you see these clients and you find that a lot of them are getting benefit, how do you feel as a provider? And secondly, what percent of your clients are actually successful in getting out of this cycle of addiction?
I would say that to answer the question about the success, that's what gets you back into the office every day. And I even tell them, I'm like, you made my day. And they can see my face light up because they know you really do develop this therapeutic relationship with your patients. And you're so hopeful and you do everything you can to help. But you also know it's also their responsibility on their end to take the reins and make those important changes that are not so simple. And it really is just incredibly fulfilling to see that. And that's why I really have really worked with buprenorphine in itself, gosh, for 20 years now, since Data 2000, when we actually had it here in the United States. It started even earlier in Europe and in the 90s, and we got it here in the 2000s. So it's just been incredible to see those changes, especially on a maintenance basis for the last 10, 15 years or so. But also, I would probably say the percentage is somewhere between, 70, even approaching 80%. There's still, some people that I could say may have switched to maybe a methadone maintenance. And I'm saying that's with buprenorphine in itself. Many people I have recommended methadone maintenance, which I don't treat with myself, but I would refer to that clinic and I would maybe monitor their mental health disorders and see some success there, but they just need a different type of treatment, or they may need a more intense level of treatment, such as a rehab or longer term. So it really depends, but I think there's potential for everyone. And the more issues that you address and the more you build that trust and treat people humanely in a non-judgmental fashion, I think the more people will respond to you. And when they're running into some roadblocks, they're more likely to be more open about what they need so that you can really help them the most you can.
Absolutely. Well, thank you so much for sharing your insights. And knowing you as a person, as a colleague, as a friend, your compassionate care, your ability to connect with your clients, I sometimes feel if that's also responsible for such a high success rate that your clients have in getting, over their challenges. So we so appreciate it, Dr. Madrick. And as you said, we'll put all these links under our videos. And any last takes? One question that just kind of came to my mind is that if we do have a person out there who listened to this program and is struggling with addiction, and somewhere in the world out there, or even in America, where is this one place that he can call for help? Like right now, is there should he just go to the ER? Should he just, like, one place where he can get help?
Right. You can just call. We have 911, and I would say that if you can just call and say, this is an emergency, or you can present to that emergency room or crisis center. Every emergency room is equipped to manage acute symptoms, and they can get you to the necessary resources. You can also talk to your primary care provider, because they are also equipped with resources and knowledge about this. So whether it's in an emergency situation or even your primary care, you can start there and they can get you the other resources that you need. But if there is one take-home point just to reduce the stigma, I would say that just keep in mind that, having an addiction can be any person. It could be young, it can be old, it could be poor, it could be the most professional. I've seen them all and in between. And every person deserves to have respect and adequate treatment. And it's not a character flaw. It's not a personality difficulty. It's a true illness that needs to be addressed that could potentially happen to anyone. And just to be as non-judgmental as possible and to treat that person with compassion and to help them to get to that next point of care that they need to get that help to save lives. And I would like to personally thank you for being a part of this. This is wonderful. Of course, I always love the opportunity to see and speak with you, but I just feel very honored to be a part of this and the great work that you're doing on so many levels to help so many people on such a big scale is just tremendous. And I just want to thank you for all the great work that you're doing as well.
Of course. Thank you so much, Dr. Madrick. So appreciate your time and so appreciate your insights. So take home message, non-judgmental approach, compassion, support, and reaching out no matter where you are. Again, thank you so much. We hope you have a wonderful rest of your journey with helping these clients.